Good evening, everybody. We're now starting this webinar. I will tell you that I'm bringing you the latest information from studies, published studies. This is so that you can take information that is factual, not what is being said and talked about on the internet, or I've seen things on Mast Cells in the Townsend letter, et cetera, that has some things that are right, but I've seen also things that are old and not really based on scientific information. So as we start this is to help you understand what mast cells do, what they can do to your patients, so that you can, tomorrow morning with your patients, start helping them and start their treatment correctly. Okay, so what do I do? Basically, I'm these are all the different editorial things that I do. I'm the editor-in-chief or co-editor of various medical journals. I'm a reviewer for other medical journals, and I'm the editorial board of others. I think that you've all seen these, and I believe that anyone who has also watched my webinars understands that how to deal is detect the cause, remove the cause, and repair the damage, and you have a patient that is healed. So let's talk about MCAS and MCAD, Mast Cell Activation Syndrome and Mast Cell Activation diseases. These are relatively new disease entities, and just to let you know, it's relatively new. Mast Cell Activation Syndrome is only 7 years old, and as such, there isn't a lot of reliable epidemiological studies for these conditions, so you can't say it affects this many people or this many women or this many men or at this age or that age. That's just to clarify a very important point. So mast cells are the first responders to most bodily invasions and insults, okay? They're highly evolved and critical components of the cellular immune system. And they support both the innate immune system, which we were born with, and the adaptive immune system that we develop throughout life, especially in the first years. Largely, these mast cells lay in wait, and these warriors spring into action if they perceive a major threat, and they released a vast array of mediators all at once. And as you well know, at the bottom of each slide, there is the medical journal study that this was gathered from. So you can look it up and actually see for yourself. So mast cells are immune sentinels, like soldiers at the environment and the host interface. They're strategically positioned in close range to blood, lymphatic vessels, nerves, and respond to allergens, which give you allergies, pathogens, which are infections, and toxins that can be ingested or inhaled. Okay, either breathed in or you get them from the world around the patient. The physiological role of mast cells extends far beyond the usual allergy, hives, itchy eyes, itchy nose, and those kind of things. They are involved in physiological processes such as the repair of tissues, wound healing, and angiogenesis, which is bringing new blood vessels to an area that needs it. Mast cells are involved in the homeostatic regulation, means the balance of the intestinal barrier. This is the gut, controlling the intestinal epithelial ion transport. The gut is lined by one layer of epithelial cells, and it controls that, and the vascular blood vessels and epithelial permeability, the peristalsis, the movement of the gut, fibrosis, which is the tissue after it's been damaged, and tissue repair, the defense against bacteria, and chemotaxis, as well as modulating both the two immune responsive, innate and adaptive immune responses. There are a multifunctional immune cell, and they orchestrate typically the allergic conditions and by allergens. It could be, like you can see, read pollen, food, medication, the venom of stinging insects such as wasps, bees, etc. And it leads to the degranulation, meaning these mast cells release granules and the elaboration of the inflammatory mediators responsible for regulating the acute, dramatic inflammatory response. So when you get bitten by even a mosquito, you start itching, you start feeling, and you scratch, and it's swollen, it's red, etc. That's all mast cell related. And they're also present in the brain, the central nervous system, especially in the meninges and the median eminence, where they are located around the blood vessels, perivascularly, close to neurons that are often positive for CRH, okay, corticotropin releasing hormone, secreted under stress. Mast cells are the richest source of histamine in the brain. And where in the amygdala, the hippocampus, the hypothalamus, and the thalamus. Brain mast cells had been termed the immune gate to the brain. Once triggered by something that attacks the body, mast cells can deploy more than 1,000 distinct self-service mediator receptors. And what does that result in? Inflammation, allergic-like symptoms and phenomena, like I talked about, the hives and all that, or altered tissue growth and development, which is called dystrophism. This is from a study by Dr. Claudia Miller at the University of Texas in San Antonio, who's been a friend of mine for 30 years or more, actually, and has written extensively in many journals. Lymphocytes, your white blood cells, take hours to activate. Neutrophils, another part of your blood, require minutes, but mast cells can respond to a trigger, an attack, in sub-second time. And mast cell activation syndrome diagnosis typically requires 3 distinct parts: chronic and or recurrent symptoms that are consistent with abnormal mast cell mediator release. Secondly, you have to exclude other conditions which may better explain the symptoms the patient is having. And third, laboratory evidence of mast cell activation. And we'll get into that in a little bit. Understandably, there's many reviews of mast cell activation disease, and they're focused on mastocytosis. Briefly, mast cell activation disease can be divided into these three parts. Primary, which is mastocytosis, monoclonal mast cell activation disorders. Secondly, allergies, asthma, cancer, urticaria. And third, idiopathic, unknown, anaphylaxis, chronic spontaneous urticaria, and mast cell activation syndrome. Anaphylaxis is when you eat something or get stung by something and it's a medical emergency. You've got to have an EpiPen, epinephrine, close by to reverse the process. The critical issue is not how to define certain syndromes, but how to define this mast cell, the activation part. For instance, many patients with mast cell activation diseases like allergies, asthma, cancer, urticarias don't have elevated levels of tryptase. This should not be a big surprise because mast cells can be stimulated by many neuroimmune endocrine triggers, including mycotoxins, leading to the release of these mediators other than histamine or tryptase. The fact that individuals often report immediate symptoms following seemingly insignificant exposures, like a whiff of a perfume. And this has led some to speculate that the mechanism must be neurological, and mast cells can explosively release at one time or slow, gradual leak their mediators. In fact, there's no cellular element of the immune system that reacts faster than mast cells. That's very important to know. So many patients with mast cell activation disease are more sensitive to excipients like additives, food colorings, preservatives, cosmetics, drugs, supplements than the average person. Okay? And there's a subgroup of mast cell activation syndrome patients that have extreme sensitivity to odors and stress. And they show up in your office with neurologic and cognitive dysfunction. And they're resistant to treatment with antihistamines and or leukotriene antagonists. When you stimulate mast cells, they rapidly secrete via degranulation. What does that mean, degranulation? Mast cells are full of little bubbles inside. Those are what we call the granules. And each one leaves the cell, this mast cell starts to secrete these little bubbles, and they have multiple mediators that include preformed granule stores, mediators such as heparin, histamine, tryptase, and tumor necrosis factor. So, for example, why does a mosquito bite get red? That's the heparin. There's more blood that is now coming to that part because it's thinner. So let's look at interleukin 6, which is one of the mediators. It's a multifunctional cytokine that regulates the immune response, that regulates inflammation, hemopoiesis, and the acute response. IL-6 has an important role in the development of autoimmune diseases. Rheumatoid factor, for example, rheumatoid diseases, rheumatoid arthritis, Hashimoto's, all the MS, all these. And it's released by mast cells when stimulated by IgE mycotoxin antibodies. IgE. So which mycotoxins can cause the release of IL-6? 9 of them. And here they are. Satratoxin, verucorol, ochratoxin, T2 toxin, alternaria, stachybotrys, aspergillus, vomitoxin, which is also known, in Europe, it's vomitoxin. In this country, it's known as deoxynivalenol. Sterigamatocystin. Sterigamatocystin is an important one, and it comes from chitomium. And these are all can be tested in blood. Now, I want to bring you to your attention ochratoxin, because ochratoxin is 99.6% bound to albumin, the #1 protein in the body. It cannot be excreted in urine. How do they find it in urine? Well, that test is not accurate in any way. So mast cell activation may explain many cases of chemical intolerance. What do I mean by that? Chemical, food, drug intolerances. These are growing all over the planet, and they arise from exposures to building construction materials or remodeling, pesticides, like either the kind you use on your lawn, in your home, on a golf course, etc., military environments such as the Gulf War and the Gulf War syndrome, combustion products, like what happened at the World Trade Center disaster, burn pits. What about the wildfires that we've seen in the news lately in California and in the United States and in other countries? Chemical spills from, we've seen how railroads will get derailed and the chemicals spills from the railroad cars, or other releases. Surgical implants, such as breast implants, molds, mycotoxins, and many other sources. Histamine is involved in the development of neurons in the brain, and it also acts as an alert signal in the brain. In fact, brain histamine is critical for arousal. Oh my gosh, something's happening. Memory consolidation and retrieval, to be able to remember something and retrieve it, and also motivation. So if you have a patient that's not motivated, that's kind of just, oh, I don't care anymore. Well, here's part of that. And here's chromalin, which is disodium chromoglycate. And it's known as a mast cell stabilizer, supposed to stabilize mast cells because it had originally been shown to inhibit histamine release from rat peritoneal mast cells. These were studies done in animals. However, chromalin does not effectively inhibit either mouse or human mast cells. So it doesn't matter about the animals. It's not even effective sometimes in humans. The first generation H1 antihistamine blockers, such as ketotifen, have been promoted as a mast cell inhibitor, but be careful, because the evidence is weak, and the medication is associated with fatigue and weight gain. Well, your patients don't want to have that. What is helpful? Low-dose naltrexone. At a conference that I attended in New Orleans, ICIM conference. Dr. Leonard Weinstock gave a presentation on low-dose naltrexone with actual patient cases, and it is very helpful in the treatment of mast cell activation syndrome. What is common in mast cell patients is low vitamin D. Up to 80% of patients with mast cell problems, mast cell activation diseases, have very low levels of vitamin D. And remember, for vitamin D, you want it between 50 and 80. And there's increasing evidence that supports the premise that vitamin D has immune regulatory actions in general, and mast cell inhibitory functions in particular. It helps inhibit functions of the mast cell. Specifically, vitamin D was reported to regulate IgE production and inhibition of IgE-dependent mast cell activation via specific vitamin D metabolites. So you can see here how it's important to get vitamin D3 levels and give your patients vitamin D3. The general amount is 5,000 international units daily. I usually use Claire Labs for that, and they have it's a capsule, and I've used it in many, many patients. Antihistamines and mast cell stabilizing agents, such as the chromalin I mentioned and ketotifen, have been used, as well as steroids and non-steroidal immunosuppressive drugs, such as these. You can read them. This is omalizumab is a monoclonal IgE antibody therapy. Although the evidence base for this, is limited. And the therapeutic success, in other words, the treatment, is it successful or not, depends on the individual patient. Just not well established. And I want to make sure you understand that it may work in a few patients, and in others, it may not work at all. Certain naturally occurring flavonoids that are found in fruits, green plants, seeds, have very potent antioxidant and anti-inflammatory properties. Among these, the flavone, it's called luteolin, stands out because it significantly inhibits the activation of both mast cells and the brain macrophages and microglia in the brain. So remember luteolin. I recommend the assistance and help from dietitians/nutritionists who understand food intolerances, food addiction, and elimination diets. Note that foods themselves may be triggers. Remember, peanuts, but food additives and chemical residues on foods are also frequent triggers. So when you see an apple at the grocery store, at the supermarket, why do you think it's shiny? Have you ever been in an apple orchard? The apples are not shiny. That's something they add on. Many patients opt for organic foods whenever they're available and affordable, and that is a big point. If you can stick to organic foods, that is very important and helpful in your patients. Now, we know that mycotoxins cross the blood-brain barrier by changing the permeability, and it induces oxidative stress responses, including reactive oxygen species generation, lipid perioxidation, and protein carbonyl formation. So we're going to move on to what about kids with autism? Many children with autism spectrum disorder have a history of allergic symptoms, often with mast cell positive tests that are negative. They're absent. And there's a study that showed that in autism spectrum disorder, there's a 10-fold increase in children with mastocytosis as compared to the general population. What about mast cells in implanted biomaterials? And I'm directing you specifically to breast implant illness and breast implants. And mast cells, which store and release all these large amounts of histamine, often are found associated with these implant surfaces. And this was shown in this study by Tang and the others. I'm going to show you now a case study. This is a young 28-year-old female with visible mold in the home. It was underneath a window. It was growing on the wall under the window. She was very active. She was doing all kinds of sports. She had an active social life, etc., until these skin lesions started 3 months before I see her. So she stays at home now because she doesn't want to go out. She has to, the people will look at her and stare at her. She'd been seeing 3 healthcare professionals who gave her binders or corticosteroids. After 1 month and no changes, she first quit the binders, then quit the steroids as she couldn't sleep due to the side effects of the steroids. That's a common side effect. And what were her main symptoms? Fatigue, nausea, all kinds of GI complaints, pain, itching, and flushing that came on suddenly. Look at the skin on her thighs. Look at what happened on the volar aspect of the forearm, just on the lower part of the forearm. So you can see these lesions. And these are typically found in mast cell activation. Look at her neck and look at her treatment. She shows her wrists and her neck afterwards. You see how it can go away with treatment, with the correct treatment. Look at her back, look at her legs, and look at after treatment. Can you see that? That is effective treatment. So let's go and show you another patient. Here's a young woman, young girl. This is her upper arm next to her shoulder on the left picture. That's her forearm. And look at her both hands afterwards. You see how they look? Clearing up and everything with correct treatment. Look at her face. This is before, and obviously she's smiling after. She was so embarrassed to go out into public, obviously. And now she's a happy camper. So let's talk about treatment. I want to make sure you understand, because a lot of healthcare professionals run and give fluconazole. Well, fluconazole treats single cell molds only. Those are all the yeasts, the kind that you use for making bread, for making alcoholic beverages, for candida, etc. It only works for that single cell. But what about Aspergillus, Stachybotrys, Penicillium, Fusarium, Chaetomium? Doesn't work. But itraconazole works against all of them. all of them. That's very important to know. So don't give them. I had one patient says, my doctor has me on both. Well, that can cause heart problems. So don't do that. Use itraconazole, and that'll help the patient. Here is the latest study on urine testing for mycotoxins published a year and a half ago, okay, in the journal Toxins. And they said that the variability of mycotoxin concentration in urine and its volume is based on daily intake, and it demands urine sampling at different time points during the day. So you can't rely on one. It changes throughout the day, and the normalization of the results with creatinine concentration. So the inter-individual comparison of mycotoxins in urine is challenging because various factors, such as are you a male or a female, age, diet, muscle mass, can influence creatinine secretion. This is basic knowledge. What did this study published in Toxins also show? That the ELISA method to detect mycotoxins in human serum, the blood test, the human blood serum test, comes with significant accuracy, precision, and specificity. Yet there's a lot of people using the urine test. I don't understand why. Here it is, the study. It's a year and a half old. This is from a slide that was at a presentation at the A4M conference in December of 2023, just a few months ago, given by Dr. Vujdani. And you can see the article where it was gotten from. What they did is they took stools from a healthy person, and it was screened for different bacteria and parasites. Then they took this healthy stool and spiked it with 14 different bacteria and 2 parasites. And then they sent it to 2 different labs. Look at the GI map that's so popular. It's only 26% specific, meaning 74% was off. Do you want to do a test where 74% of the test is in error? Please don't use that. And here's the evidence. Okay? So let me take you to the next slide from the same presentation. And it's the use of and limitations of organic acid tests for gut health. And it was from this study. Several popular organic acid tests claim to detect imbalances in gut bacteria and fungi, but most of the microbial markers on these tests do not measure what they claim to do. So stop using the organic acid test. It is not valid. It's not a good test for your patients. Stop wasting their money. And here's a great picture. Look for the body burden of chemicals, not chemicals coming out of my urine. In other words, how much is in the body, not what's left the body. So do mycotoxin antibody testing, not mycotoxin in urine that's left the body. Okay? And what is the most precise and accurate test for mycotoxins? They told you it was the ELISA test. And the MyMycoLab tests for both IgG, which is a toxic reaction, and IgE, which is the mast cell activation measurements for 14 different mycotoxins. It's also available internationally. And I've had the opportunity to speak to many, many doctors all over the world, because part of MyMycoLab testing is if you receive the results, you can have a consultation with me to go over these results and what they mean. That's very helpful. I'm sharing with you the latest published study from 2 weeks ago that was published, and the title is Mycotoxin Triggered Attacks of Nausea, Vomiting, and Abdominal Pain and Episodes of Pseudo-Obstruction. Okay? It is published in Universal Library of Medical and Health Sciences. And if you would like a copy, I'd be happy to send it to you. And there were 4 of us on this study. Dr. Jordan Gudovich is a radiologist, and we actually show X-ray pictures of the gut and how inflamed it is. And at the end of this study is several pages of a questionnaire to use in patients that you suspect have Mast Cell Activation Syndrome. So, if you have any questions, email me at immunedoctor@gmail.com. Now, let me go ahead and get into some of the questions in the chat. And normal blood test tryptase, yet all symptoms consistent with MCA, how to proceed? Well, I showed you the slide where it says that many patients don't have elevation of tryptase, okay? So you've got to be a very good and careful clinician and get a good history. The preferred dose of vitamin D, if a patient is low, is, as I mentioned in this lecture, is 5,000 international units, 1 capsule a day, and I get it from Claire Laboratories. And here's another one that my daughter has, autism and dermatographia. So that's common if in mast cell releases. So do the MyMycoLab mycotoxin test. Is it possible to get well if I'm only taking itraconazole? Might it take longer? No. You need the support of certain specific nutraceutical supplements. So if you go to MyMycoLab's YouTube channel, watch my webinars, there's 68 of them. Watch the one on treatment. Here's another question. I've been on itraconazole for 4 months. I have 2 more months, but still have skin sensitivity and redness. Would LDN be a good option? Yes, it may. So many of my patients tell me they've been counseled not to take itraconazole because the MD told them it is so dangerous, especially the liver. What is your recommendation for response? Again, if you go to the MyMycoLab's YouTube channel, there are specific webinars where I show the safety of these. Usually these MDs have never used it. Go to the internet, Dr. Google, oh, your eyes are going to fall out, your teeth are going to fall out, your hair is going to fall out, your liver is going to fall out. No, this is bunk. I've treated almost 17,000 patients. I've published over 100 articles. I have chapters in medical textbooks, and I have lectured at 6 different medical schools to faculty. Ask them if they've done any of those things. My allergist told me the same thing today, that I should look into off-label use of itraconazole and its side effects. I have no clue how to respond. That wrote me off after normal tryptase results. Well, I showed you that many patients have normal tryptase in this presentation, in this PowerPoint lecture, okay? So as a result, you have to do the correct treatment. Let me give you a very specific response. With the correct diagnosis and the correct treatment, what happens? The patient heals. You got the wrong diagnosis and or the wrong treatment, the patient continues sick. Okay? So if you want the study that was just published a couple of weeks ago, please email me. Here's my email address. I'll be happy to send it to you. I read you must take itraconazole with a full fat meal. Is this true? Oh gosh. Okay, so you're going to run to Denny's and order their Grand Slam breakfast. No, you don't need that. Itraconazole is fine with a bite of an apple or a bite of a banana. Just needs a little food to be better absorbed. And if you read something on the internet, it is opinion, it is anecdote. Get studies that show the actual medical evidence, not anecdotes, stories. Does voriconazole intravenously work as well? I'm assuming you mean as well as itraconazole? Yes. Is it safe to eat organic fruits and vegetables labeled as organic biologique? I don't know what that means. I only can tell you that the point of eating organic is there's less chemicals in it. There's less hormones, there's less additives, there's less chemicals in this. And here's another one. My good friend, Dr. Campbell, once told me the side effects of taking itraconazole is good health. That is correct. That is absolutely correct. If you have any more questions, please put them in the chat, or you can add them. You can ask me at this at my email, and I'll be happy to answer them for you. The key here to remember is you've got to take each patient as an individual. It's not one size fits all like the Shoemaker protocol, the Neil Nathan protocol, and all these protocols. Here's a question. What is the reason why a 16-year-old boy who took Sporanox for 4 months, 1 capsule twice a day, gained 20 pounds? Without knowing more, I don't know. But I'm telling you, it's not the itraconazole. And here's another one. Thank you. Since the itraconazole is advised to take for 6 months, how many IV treatments of voriconazole would it take? It depends on each patient. What are the main causes of MCAS, Mast Cell Activation Syndrome? I gave it to you in this lecture, in this presentation, and the studies where these came from. They didn't come from the internet, and they didn't come from social media. Okay? They came from actual medical and scientific evidence. And that's what you've got to go by in order to treat patients and treat them effectively and well. Are there any more questions in the chat that you'd like for me to answer? Remember, go by medical evidence. It's not one size fits all. Mast cell activation syndrome. I've seen so many patients with it. I showed you the photographs of before and after and how mycotoxin did this. And yes, you'll be able to get a recording if you go to the MyMycoLab's YouTube channel. Probably it'll be Friday or Saturday. It'll be available on there. Here's another question. I'm farm med damage. I'm also taking benzo. I react to medication. How do I take this if I'm worrying about reaction? You've got to have a doctor that understands what you're doing and how you react, not some healthcare practitioner who goes by summits and all these things. Go find a doctor that understands this because of medical and scientific evidence. Then another one. So many of my patients tell me they've been counseled not to take itraconazole because it's specially for the liver. What is your response? Well, I've given that response. How does MCAS typically present in children? Well, I showed you that. It's in the slides. The recording will be posted to YouTube. Sign up for our newsletter to be notified when it's available. Okay. Thank you, Dr. Campbell. This has been so educational. I'm a patient. As always, thank you, Dr. Campbell, for your time. I'm always available to answer your questions. You need to understand the doctors that say all this about itraconazole is mainly because they've never used it and they're scared to use it and don't want to use it and don't want to give you a prescription for it. Here's a picture. Well, there you go. Before and after. Okay. So, point is, watch the webinars I've given. I've given Mast Cell Activation Syndrome webinars in the past. This was more of a review of everything that's recently been studied and published that has not been used before. So go to the MyMycoLab's YouTube channel and you will have your answers there. Anyway, I've gone through the why and the how and the diagnostics and the treatment measures that you can use there. And I can help you with your patients who have this. If you order the MyMycoLab test, we can have a Zoom call when you have the test results and go over them and go over your patient or patients and review them together. All right. So having, you suggest nitric oxide. What if you have POTS? Can you take it without lowering blood pressure? Well, what do you think causes POTS? Mycotoxins. If you get rid of the mycotoxins, the POTS goes away. What do I do if I can't tolerate even the buffered vitamin C? Then don't take vitamin C. Do the treatment for the mycotoxins. And it's not only itraconazole. There's 4 points. The first one is the first rule of toxicology. Get the patient away from the toxin or the toxin away from the patient. You can't get well if you're still exposed to molds inside your home or workplace. Second, itraconazole, 100 milligrams twice a day. Third is the specific nutraceutical supplements from the specific labs that make them. Don't get on the internet and Amazon and order things from there, because there's a study that came out in November last year, 6 months ago, that showed that out of 60 common supplements, 11% had what is on the label in the bottle. 11%. 40% had nothing in the bottle that was on the label itself. So you don't know what you're getting if you get them from who knows where. Remember that. So it's 1, get the patient away from the toxin or the toxin away from the patients. 2, the itraconazole. 3, the specific targeted nutraceutical supplements. 4, the nutrition that I talked to you about. And those are the 4 points you need. Get tested first to know if you do have IgE antibodies to mycotoxins. Do the MyMycoLab test. It's as simple as that. And then we can talk about it over a Zoom call. Thank you, Dr. Campbell, for your wisdom and your time. Very helpful. Thank you very much for those comments. I appreciate them very much. Okay, folks. So, see you next time I'll let you know. Sign up under MyMycoLab newsletter so you get all the information you need. That is always based on medical and scientific evidence, not on opinions, not on anecdotes and stories that are throughout the internet, and not on social media. You get the real facts directly here. Okay, folks. Well, have a good rest of your day, and we'll see you soon at the next webinar. Take care. Have a wonderful weekend and a wonderful week.